Hello, everybody. Today I'm talking with Dr. Sohom. He's a forensic psychiatrist. He's author of the book In Two Minds, Stories of Murder, Justice and Recovery. He also has a YouTube channel, A Psych for Sore Minds, where he talks about mental illness and offending and true crime. And I'm absolutely excited to be talking to you today, Dr. Das.
Hi, Darren. Thank you so much for having me on. And also thank you for pronouncing my first name correctly, because a lot of people don't. Most people don't, but you nailed it.
Well, to prove that I actually watch your channel and so on, I'm just interested before we start, the difference between clinical psychiatry and forensic psychiatry. For those that don't know, what would be the difference be?
Sure. So, clinical psychiatry is really any setting where you see patients. So forensic psychiatry is a type of clinical psychiatry, but forensics specializes in dealing with people who have either committed offences and have been in and out of prison. So often we get patients transferred to our units from prison, or they might not have necessarily been charged, but they have issues with violence. For example, people that have been in psychiatric hospital for a long time who because of their symptoms can act out violently. So as I said, we assess people in prisons and in psychiatric units. The other element of it that's quite unique to forensics that isn't seen in clinical psychiatry as much is expert witness work. So I write court reports for people who are on trial, usually on remand in prison, so that I can give evidence for their court cases to help the judge make decisions.
And I'm just curious, what interested you in that side of psychiatry as opposed to maybe the clinical work?
So when I first started my psychiatry training, there's lots of different subspecialties. And as a junior psychiatrist, you do about 6 months placement in lots of different areas, different settings, different types of wards. And it was towards the end of my training that I did a 6-month placement in North London in a medium secure unit. And there was something just about this patient's stories that really fascinated me. So I think I've always had a slightly macabre interest in crime and in gangs. So, I used to listen to gangster rap when I was a kid. I used to love like all these mob films growing up as a teenager, like Goodfellas, Scarface. So I always had like a slight intrigue at the back of my mind, but I don't think I even knew that there would be a line of work that covered that when I got older. And then I got into this forensic ward. And it's almost like piecing together a puzzle of why somebody has committed serious violence and why they've ended up with a severe mental illness to the degree that they need to be sectioned. And it's often the same demographic factors or confounding factors like, poverty, being the victim of physical or sexual abuse, drug and alcohol misuse is a huge one. So it's almost like you get to be a bit of a detective because you get to delve into their background and figure out how they ended up where they did.
You're right. It is a fascinating line of work, and some of the stuff you cover on your channel, you're talking about true crime stuff. You're talking about real people. You've talked about people like Jimmy Savile and so on. There is something quite macabre about it, but it is still a fascinating line of work.
Yeah, I think there's this really big trend towards true crime, isn't there? So there's new Netflix documentaries or out. I was going to say on a weekly basis, but it seems like even more than that now. It's almost on a daily basis. I think just people are intrigued in knowing why other people commit violence. I think there's a dark side inside almost all of us, and we might have thoughts about what we might want to do to anybody that's wronged us, like an ex-partner when you've broken up with somebody, or a boss that's insulted you, but we wouldn't do anything about it. We just have the thoughts. So we're fascinated why and how people will go that step further,
or other people will act out on those thoughts.
Yeah.
Yeah, okay. So, talking about your work, be interested in talking about the work you do, the processes involved whenever you're assessing someone. If you want to talk through that.
Sure. So when I assess people for expert witness work, the main questions, I'll tell you what the focus of my assessment is, and then I'll tell you how I assess. So what the judge wants to know, what the court wants to know is, does this person have a mental illness? Yes or no? If they do, did they have symptoms at the time of their offence? Say, for example, stabbing, attempted murder, occasionally murder, yes or no? And if they did have symptoms, does that make them criminally culpable or not? And if they are criminally culpable, then they get sent to prison, rightly so, and they might have some psychiatric care in prison by visiting forensic psychiatrists such as myself. But for a very small proportion who are not criminally responsible, they might get a psychiatric defense like not guilty by reason of insanity. I'm sure you and your viewers would have heard that phrase. So then they get transferred to these secure units for long-term rehabilitation rather than prison. So that's basically what I'm trying to find out in my assessment. My assessments for medico-legal work tend to be fairly brief. So I usually get about an hour or two with the actual defendant themselves, technically called a defendant rather than a patient, before they've been transferred to hospital. And the first thing I do is I look at all the evidence before I even step foot inside the prison. So I look at the individual's psychiatric history, psychiatric notes, maybe speak to their general practitioner. And the reason is because there's usually a consistency or a pattern of mental illness. So people, for example, who are psychotic, hearing voices, they almost always have a very gradual decline over months or even years before they get to the point where they're committing violence. So I'm looking for these signs. So if, for example, somebody claims that they're hearing voices and they stab somebody for that reason, there's usually some evidence in the previous history. It's very unusual for that to happen out of the blue. It does happen, and I've seen it, but it's exceptionally rare. So that's the first thing I do. I look at all the evidence. And when I say evidence as well as medical notes, I'm looking at witness statements, occasionally CCTV footage of the actual offence itself. I read the transcripts of the police interview. So usually people are arrested within a few hours or within 24 hours and interviewed within 24 hours of the offence. So again, I'm looking for consistency of what the symptoms they report versus what is observed during police interview. So again, if somebody's telling me that they're extremely paranoid, hearing voices at the time of the offence, but they're interacting completely normally and giving a narrative to the police, then I'm suspicious. So that's all the background. And then when I actually finally see the defendant in front of me, I've got a set psychiatric history that's kind of been seared into my head after having done it several thousand times. So it would be about the background, family history, past psychiatric history, and then probably most importantly, their version of events of the alleged offence. So it's not that important for me to consider whether they're guilty or not guilty. In fact, I shouldn't really comment on that. That's only for the courts. But it's whether they've got those symptoms and whether there's a psychiatric explanation. And then obviously while I'm doing that, I'm assessing their mental state. So within your mental state, you're looking at how people are acting or interacting, and whether it's consistent with what they're reporting. So to use a previous example, if somebody's telling me they're paranoid and they have these paranoid delusions because they want to get some mitigating factors, but they're not acting in any way paranoid when I'm sitting there assessing them, or if they're not interacting in any way suspiciously or in any way guarded with the other people in the court, staff, etc., then my alarm bells, my suspicion is raised again.
Yes, it's looking for recurring patterns of behaviour.
Yeah, absolutely. And then I'll basically put all of that together into my evidence in a court report. It's a slightly different process when somebody comes into hospital for long-term rehabilitation, because you see them on a daily basis, or at least once or twice a week in the long term for months or years. So it's a very more detailed type of assessment.
I know you talk on your channel sometimes, and you discussed, I've seen in other interviews you have sometimes, and you're anonymizing people. You talk through some of the cases. Would you like to talk through one of them now?
Yeah, absolutely. I might give you a choice if you're interested. So would you rather hear about probably like the most emotional case that I've undertaken, or like a bit of a gruesome, gory one about severe self-harm, or one about a lady who I believe feigned or faked mental illness and managed to get away with her charges?
I would listen to all three. I suppose the therapist in me, well, not just the therapist in me, just the kind of person I am, I'd be very interested in the most emotional case.
Okay, let's start with that, because it might take me quite a while to get through more. So there was a young woman that I assessed, and this really stands out in my mind for a number of reasons. She was one of the first cases that I assessed when I was a junior psychiatrist, and it's the first time that I gave evidence in a murder trial at the Old Bailey. And in my book, I call her Yasmin, but I'm protecting her identity, but because that's not her real name. But she was an 18-year-old schoolgirl. She, unlike almost all of my other defendants or clients, she didn't have any history of mental health issues at all. Didn't have any antisocial behavior, never got into fights, never committed violence, was like a model pupil at home, was very, very well behaved, generally speaking, high level of functioning, was predicted A's in her A-levels. And almost out of the blue, she became psychotic. I say almost out of the blue because there was what I would call a prodrome. So there were some warning signs for a couple of weeks beforehand that she'd become psychotic, but not that she would commit horrific violence. So she started acting oddly. So she would make odd comments about seeing like shapes in the clouds, and she started wearing these strange baggy clothes, and she would listen to this weird instrumental music rather than her usual pop music. And she made some slightly paranoid accusatory comments towards her family members. So she'd accuse them of watching smut on TV, even though they were watching the usual sitcoms they usually do. So some slightly odd behavior, but nothing barn door, clearly mental illness.
And a change in character.
Yeah. For only a couple of weeks. And then what happened was, just a bit of a trigger warning for your viewers, when she was babysitting her 3-year-old nephew, she smothered him and killed him because she was suffering from these delusions, and she believed that there were demons inside of this young boy, and that by doing that she would rid him of these demons, and she believed that she could reincarnate him when the full moon came out later on that evening. And so she, in her mind, she completely was justified in what she was doing. So she didn't try and hide her acts at all. Within a couple of hours, her mother came home, and her mother obviously realized what had happened, and this young girl, Yasmin, wasn't trying to deny it in any way at all. Her mother called the police. Again, Yasmin was kind of incredulous that nobody seemed to be believing her or understanding why she did what she did. And then she was obviously arrested, spent a couple of days in the police station, and then was put in remand to Holloway Prison, which is where I assessed her. So it's shut now, but this was back in 2013, I believe. And it was really difficult to assess her because she was extremely paranoid, extremely guarded, and she wouldn't really let me into her inner thoughts or her psyche. So that was another element that really made it quite difficult, made it stand out for me. But I managed to convince the judge to transfer her while she was on remand to the medium secure unit that I was working in at the time. It was a female ward. And I had a fairly short amount of time to assess her. It was only about 8 weeks before her trial started at the Old Bailey. And I was convinced that she had a mental illness. So even on the ward, on the surface, she seemed fairly normal, but extremely vacant. Like she would literally sit there for hours just staring into space. But she would let slip these very strange comments about reincarnation. And she asked me to print off all this information about these different religions. And bear in mind, she wasn't religious at all before any of this happened. And then when I would ask her why she was asking these questions, she would shut down and become quite defensive. So I was convinced that she had schizoaffective disorder. So I had to piece together all the different bits of information, including reports from her family about her strange behavior, some of the stuff that she said in the police station and in prison, and make the argument that it would be suitable for her to have a psychiatric defense. And the judge agreed. And I think that was the right call, because had the Crown Prosecution Service were pushing for her to get a life sentence, so she probably would have spent most of her life in prison. And because she had no insight, she would not have accepted any medication, I don't believe, and she would have remained psychotic. And because she was quite quiet as opposed to agitated, I don't think she would have got the attention of psychiatric services. So I think she would have just festered in psychosis in the long term. But instead, she was transferred on a hospital order to our ward, and she had about 3.5 years of long-term rehabilitation. The first challenge was to actually medicate her, because she refused oral medication. So we had to inject her with like depot antipsychotics for a short while, and then she agreed to take tablets. And then it took a while, it took about 18 months, but her psychosis kind of cleared, and she became more like her previous normal self. And then, so for the first 12 to 18 months, she still believed her delusions. So she still didn't believe that her nephew was dead. She thought that everybody was part of a conspiracy and that he was fine. And it took that long for her to actually accept reality and realize what she'd done. And as you'd expect, there was this huge wave of depression that came over her after that. She was trying to come to terms with the consequences of what she did. She killed her nephew. And on top of all of that, so we had to treat that as well. That was a different sort of element of her treatment that she needed. And then on top of all of that, we had to try and reconnect her with her family, including her brother, who was the father of the child that she killed. So I would sit within the family therapy environment on a weekly basis and try and sort of reconnect to this relationship that had been broken. So yeah, so that case stands out for me for so many reasons. I mean, obviously the biggest reason is just the horrific nature of the consequences of mental illness, but also like just the nervousness and the anxiety that I had giving evidence in the Old Bailey for the first time, and the emotional kind of impact of her coming to terms with what happened and trying to reconnect with her brother.
Yeah, no, this is the therapist in me talking. There's no way that could not affect you. Working with something, especially where children are involved, I think it's hardwired into us to be very protective of children, isn't it?
Yeah, and oddly, so a lot of the defendants that I see are very demographically different from Yasmin. So some of them are quite antisocial. Some of them have a long history of violence. Some of them, if I'm being blunt, if I'm being completely honest, can be quite difficult. They'd be very challenging. They'd be quite hostile. But when you have somebody that's done something this horrific, but is actually quite vulnerable herself, then yeah, as you say, it's just quite hard to kind of get past that emotional barrier.
I'm also curious as well. Now, you're probably aware in my line of work, I have things like clinical supervision. People bring a lot of things, a lot of their traumas, a lot of their stresses, a lot of their difficulties. How do you manage cases like that? Do you have the same kind of support network and supervision and so on?
Yeah, so in that particular case, I was a registrar, so I was a middle grade psychiatrist. So I had a consultant who was really good, actually, probably one of the best ones that I've worked for, who actually gave me the responsibility of giving evidence at the Old Bailey because he knew that I'd learned so much from the case. So in that particular case, it was very easy because he was part of the team. We would have a weekly 1 hour supervision where we could talk about anything that was on my mind. So that was really helpful for that particular scenario. Since I became a consultant, which is 2014, we did in the first medium secure hospital that I worked in, we did have hourly supervision with a more experienced consultant. But if I'm being completely honest, I didn't find it that helpful, simply because the way it was set up, the person who would give me supervision wasn't a doctor who worked in our hospital. He was quite distant. He didn't really know any of my patients, and it just felt a bit kind of forced. It felt like a tick boxing exercise where you have to fill your hour per week with something to talk about, but he was so far removed, physically and with the actual details. Yeah, that it didn't feel that helpful for me. It was more like an inconvenience, and being a consultant, especially when you're getting used to it, is such a busy, intense job that just one extra meeting per week for an hour is just an inconvenience more than anything.
One of the questions that's come up on my channel is about misdiagnosis. Now, it's something you mentioned, and I know you've talked about it on your channel. It was someone that you had been seeing, someone you were assessing, and to paraphrase it, you thought they were winging it. You thought they were faking it. Be okay to talk about that, because it's, if you will, it's like answering the question the opposite way around. You okay to talk through that?
Yeah. So you asked me about the case with the lady who committed fraud. Yeah, sure. So again, I talk about her in my book. Another shameless plug. So I call her Darren in my book, and again, that's not her real name. So this was a woman who I saw who had allegedly committed quite serious fraud. So she was one of 3 co-defendants. The other 2 were her cousin and her ex-boss, who she had an affair with for a couple of years. And those 2 men committed the majority of the fraud. It was carbon credit fraud, which I don't fully understand, but what I do understand is they were going around big businesses and making promises about investing in carbon credits, taking a lot of money, and then just basically scarpering. And this woman, Darina, she didn't do any of the original contacts, but she helped launder the money by channeling it through various accounts. And then all 3 of them were caught, and they went on trial. And just by an coincidence, I suppose you call it an unlucky kind of a timeline, her younger child, her 3-year-old son, became quite unwell with cancer. And he was really unwell. He was on the border of actually losing his life. And so very reasonably, her trial was stayed. So her part of the trial was kind of frozen, and the other two were tried, both found guilty, both convicted, both imprisoned. And then eventually her son got better, but he was still kind of on the verge, so he could have relapsed at any moment. And when I saw her, it was about a year after the original trial. And she'd already been seen by another forensic psychiatrist, one of my colleagues for the defense. And when he assessed her, she was very emotional. She was very tearful. In the weeks leading up to that, she had completely disengaged with the court process. So she wasn't opening any letters or answering any calls from her solicitors. And when they did manage to corner her, she would just have this flood of tears. And this other expert witness, psychiatrist, thought that she was too depressed and too emotionally fragile to go through the court process. So she found her unfit to plead. And the Crown Prosecution Service rightly had suspicions about this, and they instructed me. So when I assessed Darina, there were alarm bells kind of ringing, because there was just an inconsistency in what she was saying. So it's a bit like what I was talking about before. You always have to look for signs of consistency. You can't just take the presentation in front of you. So to be specific, she was able to detail her background history very well. So she's able to tell me about her childhood, previous psychiatric issues. But when I asked her about the offence, then she started crying profusely. She was kind of quite passive aggressive. She was accusing me of trying to take her children away from her, by which my interpretation of that was that if I helped with this process, and if she went to trial and she was found guilty, then she would be imprisoned and she'd be separated from her children. And there was just something that didn't quite add up for me. And I think I was probably slightly less gullible, empathetic, I'm not sure what the adjective is, than my colleague, in that I'd let her cry, but I didn't stop the assessment. I carried on, I let her compose herself, and I carried on asking the questions. And then her countenance changed, and she changed from being emotional and tearful to actually quite verbally hostile, which again made me a bit suspicious. And she just kind of refused to answer my questions eventually. So I concluded in my evidence that she was intentionally avoiding the situation and avoiding the questions, and that she was technically fit to plead, even though she couldn't engage in the process of my assessment. And I wrote all of that in a lot of detail in my report. I was called to the stand to give evidence, which always happens when you have two different experts with opposing opinions. And I made it crystal clear that there might be humanitarian reasons to not try her. Mm-hmm. So if the judge thinks that she is, just too vulnerable given what's going on with the child, and that's fine. But psychiatrically, there's no psychiatric reason, in my opinion, that she wasn't fit to plead. And I thought I made a very strong case. And then I was kind of shocked that the judge, despite everything that I'd said in my report, took the side of the other expert. So he declared her unfit to plead. And I think that's probably related, I'm speculating here, to some consolation in that the main two culprits were already imprisoned. And I think the judge just didn't, I don't think it was a good look to be dragging this woman through the trial. But it kind of frustrates me, because it feels like the judge was also using mental illness as a bit of a smokescreen to get around this awkward issue, rather than the humanitarian reasons. So yeah, that was very frustrating for me.
Well, as you know, I'm not in the position to diagnose anybody. That doesn't mean I can't have an opinion. You mentioned the word avoidance. That's what that sounds like. It's avoidance. The type of avoidance that you described sounds leaning very strongly towards narcissistic kind of avoidance, just avoidance of responsibility.
Yeah.
If being a victim here of pleading, if that doesn't work, then I'll try something else. If that doesn't work, I'll try something else. And ultimately, if that doesn't work, then I'll lash out aggressively.
Yeah, absolutely. So can I ask you, Darren, do you, in your line of work, I imagine you don't get people that feign or exaggerate symptoms, right? Because they're there purely for clinical benefit, as opposed to, having another agenda like medico-legally. Is that correct?
Mostly, yeah. Most people are self-referred. Occasionally I would get people who have maybe they've come through their solicitor. It could be, a breakup. It could be they've been in an accident. It could be trauma. Sometimes where I work is my practice is in a private medical practice, so there's a lot of different types of consultants. So sometimes people will come to me for trauma. They're being referred for trauma, or maybe someone's been recently diagnosed ADHD or PTSD or something. So I would get referrals that way. Very rarely when I get someone who is, I don't know if you're familiar with this phrase, but we have a phrase where I come from. Very rarely would I get someone who's just swinging the lead. That's not to say it doesn't happen, but it's very rarely.
I see people who would be swinging the lead relatively frequently. I'd say maybe once every 2 or 3 months, I come across a case where I'm suspicious that somebody's feigning or exaggerating. Yeah.
On that, I'm curious because there's a lot of what we would see crossovers. We mentioned narcissism a moment ago. Narcissism can often be just a component of something. It can be co-occurring with someone. It's not necessarily the thing itself. There are a lot of crossovers and a lot of disorders, a lot of mental illness and so on. For instance, a lot of what you might see in complex post-traumatic stress would be very similar to what you would see in borderline personality. Sometimes one might cause the other.
Yeah.
I'm just wondering, from your perspective, as you're working with people and you're diagnosing people, how do you differentiate? How do you figure out, and what's the word I'm looking for? How do you know which is which?
So I think that it's often not done particularly well, to be frank. So I can definitely think of some patients. So not so much in the medico-legal expert witness work, because as I said, I only really have an hour or two with the patient. But for the long-term secure unit work, where the patients are sectioned for months, if not years, you really get to see them on a regular basis for a long period of time, so you can observe their behaviour. So I suppose for the expert witness work, I diagnose tentatively, and I rely quite heavily on previous medical notes.
Mm.
With the actual long-term rehabilitation, I think it depends on the context. So if you take your specific example, so just very briefly for your viewers, the difference between, so PTSD is a reaction to extreme stress. The core symptoms would be reliving the experience, so flashbacks, nightmares, like a hypervigilance, which is always being on edge, and a numbness, emotional numbness, and kind of avoidance behavior, so intentionally avoiding situations that will re-trigger those traumas. Right, so that's PTSD. Complex PTSD is all of those things, plus you tend to have a lot more emotional dysregulation. There tend to be outbursts of anger. There can be worthlessness, hopelessness. They tend to be quite socially isolated. They avoid kind of friendships. Plus, they disassociate, which means they can kind of step back from reality or have experiences outside of feeling real, or the world feeling real. So that's just very briefly the difference between the two things. Complex PTSD is usually repeated horrific trauma, like, for example, being sexually abused on a regular basis from a family member. That happens frequently over a long period of time. So to answer your question, you look at the context. Somebody is more likely to have those symptoms if you can define trauma, number one, and also if the symptoms are related to that trauma. So flashbacks obviously are going to be related to that trauma. With difficulty in regulating emotions, it's likely to be related to reminders or triggers of that trauma. Whereas somebody with borderline, for example, it tends to be a lot more ingrained. So it's not just in a certain context, like being reminded of similar traumatic events. It's kind of an everyday issue that affects all of their interactions. So there's usually slight differences both within the symptomatology, but I would argue more importantly within the context of where those symptoms actually occur. And as I say, it's a lot easier to do over a long period of time. And it's okay to change your diagnosis as well. I think you have to be open-minded as psychiatrists and psychologists. So you might see a certain set of symptoms when somebody first comes into hospital, and over time, with treatment, sometimes their actual symptomatology changes, or you see it in different kind of scenarios. So you just have to be quite vigilant and open-minded, and be willing to look back at the diagnostic criteria and potentially change your mind in which category it fits into most conveniently.
No, I think that's a really good explanation. I think, particularly when we're talking about trauma, it's like everybody in the world has PTSD. We might have traumatic stress in certain situations, and we might even have post-traumatic stress given a particular offense, but or event rather. It's looking at the key word. I often think is the word disorder. It's what makes it a disorder. I your opinion in this is, you're on a higher pay grade than me, so you have every right to agree. I often think of a disorder as the impact it has on someone's day-to-day functioning.
Yeah.
And the impact it has on the relationship with the world around them, as well as with themselves. And I would agree with what you say, that diagnosis does not have to necessarily be there forever, because people
Yeah,
do learn to manage their trauma. They manage it very well. I mean, a very basic kind of CBD technique, CBT rather, is updating the memory. Particularly with complex trauma, I think it's like yesterday's threat is present today. Yesterday's situation is present today. And every time someone goes into a situation, somebody, it reminds them of somebody, or it feels the same, it looks the same, whatever, it's almost like they're right back there. And one of those techniques is updating people's memories, and putting in a lot of hard work, and with the right kind of support, those symptoms can lower. It's not. I don't think nobody ever really fully gets rid of their triggers, but I don't think it's a good idea, even if we did, because those triggers are there to inform us, not necessarily dictate the next action. We just learn to manage them better.
Yeah, absolutely. And going back to something that you said earlier, I completely agree. For me, the differentiating factor between somebody having a disorder and subclinical symptoms is their functioning. And I think you could probably stretch that to pretty much any psychiatric disorder. So people can have periods of low mood, they can be sad, but that's not clinical depression in my view until it's impacting your functioning, until you're struggling to form relationships, struggling to work, struggling to get out of bed, struggling with energy and motivation. And I suppose as a psychiatrist, it's a slight battle, because there's all these like fancy diagnostic criteria, and some of them are complicated and some of them are, in my view, are overcomplicated. Like, there's literally a list of symptoms, and if you have over a certain number, then by definition in the DSM, you have the disorder. But that doesn't really make sense to me, because you could have all of those symptoms but actually manage yourself very well and function really, really highly. Or conversely, you might not have many of the features, but they could be crippling in terms of your functioning. So I think that's more important than any kind of diagnostic criteria. And just to add to that, I think that something that gets conflated is having features or symptoms of a disorder and actually having the diagnosis. So I think we mentioned narcissism before. I think that's a perfect example. So, you watch all these YouTube videos and, comments on various high profile cases, and, I'm guilty of this myself when I make these kind of videos, but you hear the terms like narcissism banded about. Now, somebody can be narcissistic or have narcissistic traits in certain circumstances, but that's not the same as narcissistic personality disorder. So personality disorders, as you know probably better than I do, is something that's much more ingrained, and it affects all aspects of your life and your interactions. So somebody doesn't have to be both of those things. You can be narcissistic without having a personality disorder.
Yeah, I think one of the most unpopular things I ever said, one time I was giving a talk, people were asking me to talk about abusive relationships, and the word that kept getting used was narcissism. And all I did was say, sometimes you have to tap into your inner narcissist. You have to let them off the leash once in a while.
Yeah.
And, it's almost like they're going to burn me at the stake, narcissism, it's like anything we call, say, a personality disorder, avoidant and all the rest of it. Every single one of us have the characteristics. There's a normal, healthy level. When, the example I use about narcissism is you go on a date with someone, you comb the hair, you put on your best dancing trousers, you want them to really like you. You hope that you're going to like them. They're going to, that's your narcissism.
Yeah.
But it's healthy. You apply for a promotion in work, or you want to apply for a better job. That's your narcissism. You want a better quality of life. That's your narcissism. There's a healthy level. That's what I mean sometimes by tapping into your inner narcissist.
Yeah. I think it's a little bit semantic, isn't it? Because some people would use the word confidence rather than narcissism there. And there is a massive overlap between those things. But I think because of things like narcissistic personality disorder, the general public, make an assumption that narcissism is only a disadvantage or a bad thing.
It certainly can be when it's, we said before, when it's long-term, when it's pervasive. Some of the things I say in my videos, when I just outline the characteristics before I talk about whatever it is, I try to make it clear that these things are not just once in a while. Not just in certain situations. It's long term. It's like a default setting. And the same could be said for things like avoidant personality. There are some things that are not in our best interest. If we can get out of it, we will. But that's not the same as avoiding anything that brings up any kind of emotional distress.
And there are also people that are actually just lack confidence or are a bit shy, but they function absolutely fine. You know, they don't have a personality disorder. And there are people who are narcissistic who are, you know, I can even think of some of my own friends who are just a little bit cocky, and, you know, we tease them a little bit, and it's funny, but it's not a personality disorder, because, you know, it's only in the context of showing off to your mates versus, you know, not being able to maintain a relationship because you're so self-centered. They're two very different things.
And I think it's interesting these days. I mean, looking more and more into, you know, the dark personality, things like the dark triad, the dark tetrad, and all the different qualities. And that word narcissism, we would just say a narcissist is a narcissist, where the narcissism is only a component. There's so many other things. There's, you know, like the antisocial element. There's the callousness. There's the sadistic behavior. There's the Machiavellianism. There's a lot of different stuff going on there. As you know, I think of if you were to think of a narcissist, just a narcissist, just pure simple narcissism, all you have is somebody who's self-absorbed.
Yeah,
That's all it is. It's when the other things are co-occurring at the same time. That's when you get the abuser. That's when you get the abusive person. That's when you get the huge sense of entitlement and so.
yeah, yeah. And we kind of touched on this before, but you can be self-absorbed in some situations and not others if it serves you to be self-absorbed. Like, again, if you're showing off to your friends and you're kind of, you know, banter, I guess is another word for it. That doesn't mean, because you do it in that circumstance, doesn't mean that you can't have empathy or can't care
Yeah,
about other people in another circumstance.
absolutely. And you know, I suppose to give a personal example, every time I put the camera on to do a YouTube channel, I am so self-conscious. Am I pronouncing this right? Do I look like a prat? Yeah. So there is that healthy level in certain situations. But I'm interested as well to talk to you about, because you've mentioned it once or twice in your channel, just about the treatment. Sometimes you do treatment, and you mentioned earlier on about doing family work as well. Difference, I suppose, from a therapist perspective. I mean, I would work on a lot of theory. I would work on a lot of therapeutic approaches. Your work, I'm imagining, so correct me if I'm wrong, you're working from maybe a medical model?
Yeah, absolutely. Yeah.
Yeah. Why would you work with something like, say, trauma, borderline, narcissism, whatever it is? I'm sure there's maybe different approaches, but what's the difference in the medical model?
Sure. So again, this is probably more relevant for the patients that are inpatients in hospital for long-term treatment rather than the one-off assessments that I do for the court. When we have people that come through the secure system, they are by definition very risky and very dangerous. So we have a lot of resources and a lot of time to try and relieve the features that are linked to a risk of future violence compared to most psychiatric wards. And so the psychologists have a very different role from psychiatrists. So psychiatrists use a medical model. A lot of my patients, I wouldn't say all of them, but certainly majority have some sort of psychotic disorder and they need medication. So antipsychotics are much more effective in severe psychosis to reduce things like auditory hallucinations, delusions. And then after you do that, then you look at the personality, because you can't really give anybody therapy if they're actually actively psychotic or not effectively. So then that's when the role of the psychologist comes in. So we can certainly prescribe some medications if it's appropriate that might take the edge of some of the symptoms. So for example, for either PTSD or for borderline people who have unstable moods, we can give them antidepressants that might help reduce their symptoms, but they're not going to change their personality. Like, no medication can do that, as you know, and it's not going to get to the core of what caused it in the first place. So I would say that for personality issues and trauma issues, the psychology is the most helpful thing. So to pick apart exactly what happened and the thought processes and the traumatic memories layered and the reactions connected to all of that. So I think you have to have both. You have to have the kind of medical medication model and the therapeutic model going hand in hand. And that's actually done quite well, I would say, in forensic wards, simply because we have the time and we have the resources. And we have psychologists on the team, so we'd have a ward round and would speak on at least a weekly basis about how patients are progressing and tailor different aspects of the therapy. So for example, if psychotic symptoms are re-emerging, then my role would be to increase the medication, or vice versa, if they're improving and the side effects, to decrease the medication. And if there are more kind of behavioral outbursts, then it would be the psychologist's role to either intensify the therapy or to set in a behavioral plan. But we kind of work in a synergy, we work together. Yeah.
From my perspective, when I'm working with people, you're right, there's some people you can't work with because maybe they do need to be medicated. There's psychosis, and there's not necessarily any reframing exercises necessarily going to help. That might help them in a moment, but might not necessarily help them by the time they leave. So there are some cases where maybe you can't work. There maybe has to be a medical thing, but working that joint up approach, if you will, I have found sometimes working with people who have presented with different kinds of disorders and mental illness and so on. The joint up approach does seem to work the best. I'm not necessarily there as their primary source of support. I'm just one part in a multidisciplinary team, maybe.
Yeah. And I have to say, as I was saying that I think it's done well on forensic wards, conversely, I've seen it done in a very ineffective and very disjointed manner in other kind of settings. And I think that's all to do with lack of resources, often lack of time, sometimes a difference of opinions between the different specialists. So it's a shame to see that. So I remember working in a hospital when I did a CAMS placement when I was a junior doctor, and there was just a bit of discomfort, hostility between the psychiatrist and the psychologist. And, we go into these MDT meetings and they would passively aggressively argue with each other, with the psychiatrist wanting to take over and medicate and the psychologist wanting to, only do talking therapy and wanting to decrease medication. So it's a shame to see that when you have these specialties that don't work together. I think it works well in forensic units because, as I was saying before, the patient's there for such a long period of time. There's not this pressure to just, quickly fix people and move on. And because we work quite intimately together on the same wards at the same time, so we get to know each other and work as a team. So I guess the point I'm trying to make is, in theory, everything should have an MDT approach, a multidisciplinary approch. But in practice, you need the individuals to kind of want to work together and have the space to work together as well.
Yeah. And it's interesting. Again, I'd like your thoughts on this. Working with different kinds of disorders. For example, we mentioned borderline personality. Now, dialectical behavioral therapy has proven to be very popular and quite effective with borderline, in the sense that it's helping people to learn how to regulate, how they feel, regulate their behavior, their emotions, and things like helping to ground themselves. A lot of people with borderline personality are finding that very helpful. The difficulty being that would be the pros. The cons would be, in those intense moments. Now, I think even with borderline, there's even 4 subtypes within borderline, but with borderline personality, there can still be that impulsive kind of outburst. It's almost immediate. It's very difficult, not for everybody, but with a lot of people with borderline, it can be very difficult to implement some of those strategies in those intense moments. I'm just wondering your thoughts on that. I'm picking your brains here, but
Yeah, so absolutely, that's something I'd say. So I'll preface that by saying that of the personality disorders that I see in my patient cohort, especially the ones that go for the long-term rehabilitation, by far the most common one is antisocial. And by far the second most common is borderline. So antisocial people, as you will know, who lack empathy. They're like borderlines. They can be quite impulsive. They don't learn from their lessons. They don't care about the rights and wrongs of other people. Borderline people that suffer from borderline personality disorder, in my opinion, are different in that antisocial people want to offend. That's their lifestyle. That's basically who they are, what they do. Drug dealers, thugs. People with borderline, they don't want to offend, but they can't control their emotions in that moment. So they might commit extreme violence in the context of arguing with their partner, their boyfriend, their girlfriend, for example, and then they regret it afterwards. So they have this a massive reaction, and then later can see that they overreacted and want to change. Well, I'll take that back. Not everybody with borderline wants to change, but from my experience, people that go through the cycle of it happening again and again when there's consequences. So people that I've seen that go in and out of prison for assaults, for example, they have this internal epiphany. So to answer your question, first of all, I think you need an internal epiphany, no matter what personality disorder you have. There's no point having different people, smarmy doctors telling you there's something wrong with you, we need to change you. That's never going to work. They have to have motivation for themselves. That's the first thing I'd say. And the second thing I'd say is that from my experience, you're right, people with borderline who have this DBT won't remember it at the moment, and they will still explode because that's in their very nature by definition. But you can still learn after the fact, after it's happened. So it might not be the first time it happened or the second or the third, but say if somebody's in an inpatient ward and they've had, say, 5 incidents within a year, and there's consequences to those incidents, so their medication is increased or their leave is stopped from the hospital, or in extreme cases, they need to go to the seclusion room because they were that sort of dangerous at the time. Bearing in mind that people in my units tend to have quite a high risk of violence. Then over time, even though they didn't understand in that moment what was happening, they will remember the next time it's happening. They're more likely to think, this happened a month ago and I ended up really hurting somebody that I live with on the ward, might even be my friend at times. I ended up in seclusion. My leave was stopped for a month. So I think it is possible, even though you might not reflect on your behavior in that moment in time, it is possible to learn and preempt yourself to know that you're becoming distressed when it happens again in the future.
Yeah, it's one of the things I would talk about in therapy with a lot of my clients. We learn from the things that work. We build on the things that work. We learn to adapt to things that work, but we also have to learn from the things that didn't work. I say to almost every client I have, it comes to me, and whatever it is, you're talking about coping strategies, and I'm a big fan of coping strategies. God knows I use tons of them myself. But when it comes to coping strategies, looking at things the opposite way around can be very helpful. Let's start ruling out what doesn't work.
Yeah.
When you start ruling out what doesn't work, sometimes we don't need a coping strategy, or maybe we don't need as much, or we don't need to manage as much. So you're right, learning from things, what didn't work the last time. So can we rule that out?
Absolutely, yeah.
And you're absolutely right as well. And it's a question that comes up on my channel all the time. And a lot of people ask me about narcissism. And one of the questions that comes up quite a lot is, can narcissistic people change? And I answered it in quite a few videos, that pretty much the way you've just answered it as well. It's like anything, they have to want to.
Yeah.
And some people do. There are some people who can be very narcissistic, but they recognize, I keep pushing people away.
Yeah.
I am alone. I don't have any friends. I have, people around me, but they don't stay long. Or I will never get that promotion. I will never advance in here. So something has to change. I think it's common with everybody. Anybody who comes to me, asked earlier on about, we were talking about swinging the lead. Most people who come to therapy is because they recognize something's not working. Something has to change. Something has to be different.
Yeah.
And
I would argue that it's probably harder for a narcissist to change, or somebody with narcissistic PD, I should say, than probably any other personality disorder, simply because the core of narcissism is this grandiosity of believing that you're right and everybody else is wrong. Right. So if you're in your 20s and you're struggling with relationships and you're pushing people away and people don't like you, then it's quite easy for you to think, the whole world doesn't get me. I'm better than these people. I'm smarter. I'm cleverer. I'm funnier. And you can live with those thoughts, and that's fine. Happens in your 30s, happens in your 40s. You've had failed relationships. The people around you that you're friends with are all grown up and they've got married and they have children, and you feel that something's missing in your life. Then you're more likely to reflect, even though at your core you still might be narcissistic. You're more likely to think, well, hang on, maybe there is, even though it doesn't feel like there's anything wrong with me, and I want the rest of the world to think the way that I'm thinking. Maybe there is something wrong with, well, not necessarily wrong, but something different about the way that I think.
Yeah, and that epiphany, if you will, is what would need to be different. Now, the core might not necessarily change. There's still the entitlement and so on.
Yeah.
Sometimes, particularly working with narcissism, you're looking at behavioral change. And, again, it's very CBT kind of approach. Your thoughts, your feelings, and behaviors are all linked. One small change in one of those areas being consistent over a long period of time, sometimes you begin to see a knock-on effect in the other two. And with something like narcissism, you can't necessarily change the belief system because there's such a weak ego there. So it's maybe looking at changing behavior. And just interesting, I would like to, again, pick your brains on this. That lack of empathy, we talk about a lack of empathy. It's not no empathy. It's what you might call a cognitive empathy, as you're aware. It's like an intellectual empathy. So it's not no empathy. There is an understanding. Empathy is actually one of the things that I would use if I'm working with someone who's narcissistic or has narcissistic personality, or very strong narcissistic traits. A lot of people I see would be subclinical as opposed to have a diagnosis. And that works in the sense that sometimes it can help diffuse situations. It can show that you're understanding. The person's actually being heard and they're actually being listened to. So they might be a little bit more open. Not immediately, but over a period of time, they actually talk about things a little more in depth.
Yeah.
The downside of that is when you're showing empathy, they have your attention. And a lot of the time, that's what they want.
Yeah.
It's a difficult kind of balancing act sometimes.
Yeah. Yeah, I agree. I think I've been asked, I can't remember which context it was. I think it was an interview similar to this. And somebody asked me, like, how do you know if somebody's a narcissist? And apart from the obvious things like, the lack of empathy and the grandiosity, you will see that all conversations kind of turn to them. Everything's about them eventually. And they might feign, and actually that's not fair. They might actually be interested in you and your woes and your problems for a short period of time, but it is a short period of time. And then you end
It
up
immediately
going
comes
back
back.
around to them. Yeah.
It's what this is about me and all that sort of thing. What this means to me, what this has done to me. And again, the difficulty with something like narcissism, like I've mentioned this a couple of times. If the fault lies outside of them, then so does the solution.
Yeah. I
It's
like that
everybody.
phrase. Yeah.
It's everybody else has to change. It's everybody else has to do something.
Yeah.
And it can take a lot of hard work, a lot of patience and perseverance. Again, sometimes it's behavioral, looking at managing behaviors to get to that point where it's, well, maybe there is something I can do that might change this that doesn't actually mean having to manipulate. Do you know what I mean? It's
Yeah. Yeah.
can be quite a journey.
I've got a question for you. Sorry, Darren. I presume you see people with narcissistic personality disorder, right? In
I've
your therapy.
only ever seen one person with an actual diagnosis. A lot of the people I would say would be subclinical, or the narcissism would be part of something else. It
Right.
could be part of an addiction. It could be part of antisocial. I've had that antisocial
Yeah.
personality and so on. So the narcissism would be co-occurring with other things.
So I suppose I was just wondering, do you think it's harder compared to other personality issues to resolve the narcissistic tendencies? I suppose it's
Short
quite hard for you
answer:
to answer if you've only really seen one with a pure
with
diagnosis.
one with
Isn't
a
it?
full-on diagnosis, and yes, that was very difficult. That was very difficult, and like everyone else, I was the problem. I was the wrong therapist. I think regardless of where anyone is, I always remember my clinical supervisor. The very first time I was seeing someone who had an actual diagnosis, and it was borderline personality. And I discussed with my clinical supervisor, am I proficient enough? Am I going to have the skill set? Am I going to have to look up? My clinical supervisor gave me a piece of advice that's always stuck with me. She says, "Why? Why are they coming?
Sorry, say that again. Why?
Why? Why are they coming to see you?
Why they come to see you? Yeah.
What are we talking about here? Is it a bereavement? Is it relationship problems? Is it stress at work? Are they coming because they have borderline personality? You've no idea why they're there to see you yet. All they've done is
Yeah.
make an inquiry." And what she reminded me was, you're working with a person. You're working with a
Yeah.
human being. Now, the diagnosis, whatever it is, can inform you, but you're still working with an individual.
Yeah.
And it's really what it is they're presenting with and how you can best support them. So that advice it's always stuck with me. Because when I'm working with someone, even someone who has an addiction, a drug addiction, alcoholism, regardless of what it is, you're working with a human being. And as much as there are commonalities in all of us, which is why I do a video, common behaviors of this, when I talk about it, just the common behaviors. As much as there are commonalities in all of us, we're all unique individuals. And even with a personality disorder, yourself, there's maybe 9 criteria. A person only has to hit 5. So how many combinations is that?
Yeah, absolutely.
So you're working with a spectrum.
Yeah.
Some people call it a continuum. I call it a spectrum. Many different colors, many different shades, many different tones. So you're working with the individual. It's not for me anyway, it's not a one-size-fits-all answer for anybody. Now, I've worked with couples, and one of them has come, and they might be very strongly narcissistic, but they do still love their partner. They don't want to lose their partner. They don't want to end it.
Yeah.
And again, it might take a little bit of work, but it's how do you get the two of them to work together?
Yeah, absolutely.
How do you tap into that? Again, the person does have empathy. How do you get them to tap into it without feeling threatened? To feel safe, to feel safe to be emotionally intimate. And some people can. It's hard work, but they can, and it does take a lot of trust. It does mean taking risks. But then there are others who just nope. He has to change. She has to change. Nothing to do with me.
Yeah, I can
So
totally see that. Yeah.
it really depends on the person, I think. The last thing I'm going to ask, and it's the one we didn't talk about, and it is the dark part of me. Your most gruesome case.
Okay. So again, I talked about this in my book. So there was a man who was in prison,
Mhm.
and his offence wasn't really that serious. It was actually quite tragic, to be honest. He was charged with arson because he set a flat on fire as a suicide attempt. So he was there. He was rescued, went to prison for a relatively short period of time, and whilst he was in prison, he just didn't fit in with any of the other prisoners. He was an alcoholic. He was quite a shy, timid man. He got bullied instantly, and some of the other prisoners made fun of him and would target him. So they made these lies up about how he was a I'm not going to say the word for YouTube, but an offender towards young children, and also that he'd killed his partner in this fire, which is completely not true. And so because of that, these rumors kind of spread, and a lot of other prisoners believed it to be true, or them to be true. So he got targeted and he was bullied. He was kind of assaulted on a regular basis. So he was just having a horrific time. As I say, very, very tragic. And quite unusually, he developed a psychosis because he was under such stress. And he's in his mid 40s, I believe, late 40s at this time. And it's very unusual for somebody to develop a psychosis that late in life. So I think that just really shows how much stress he was under. And in his psychotic state, he believed that other prisoners wanted to kill him, remove his eyeballs, and eat his eyeballs so that they had this superhuman strength so that they could break out of prison. So in his head, the only way that he could survive this would be by taking out his eyeballs himself and offering them to the other prisoners. So
Wow.
that is pretty much exactly what happened. So he was the reason that I assessed him, and I assessed him, I should say, a couple of years after this happened, was because it was a civil case rather than a criminal case. And he was suing the prison medical team, mental health team, for not keeping him safe. Number one, for not actually recognizing the psychosis in time to intervene. And number two, he was suing the actual prison officers for not physically preventing him. In actuality, it was witnessed. So the first one was done with a plastic fork, which snapped, and the second one he just did literally with his own fingers. And this was witnessed by a nurse, but she very reasonably, in my opinion, didn't want to go into the room because of the level of danger. So she had to call for backup for the other prison officers to come in and get what we call kitted up. So all their protective gear, their riot gear put on before they could open the door. And they did this in about 7 or 8 minutes, which is actually pretty quick compared to typical times. But by the time they'd opened the door, the deed had been done. So I assessed him retrospectively, and by the time I'd seen him, he'd completely over his psychosis, blind obviously, but absolutely lucid and actually quite well. And he was trying to argue that the mental health team should have picked up his psychosis earlier, should have transferred him to a mental health care unit, and should have medicated him much earlier. Whereas obviously I felt a lot of sympathy for the poor man, but I didn't agree with that finding because his psychosis escalated so quickly that the first symptoms or signs were only there about 2 days before. And so I don't think there's any way they could have predicted, first of all, that he'd have become that psychotic that quickly. And also, even though within those 2 days his behavior was slightly bizarre, it wasn't indicative of self-harm. So he was doing some odd things like flooding the toilets and talking about taking a chance.
He wasn't actually presenting with risk.
Yeah, he wasn't self-harming in any way at all. So, I felt for the guy, but I didn't think there was a civil case there. I don't think it would be fair for the prison estate to be sued. So yeah, that was the most gruesome kind of gory self-harm that I didn't witness it physically, but that I've come across in my career.
I don't know what to say to that.
Yeah, it's pretty shocking, isn't it?
It is, yeah. I mean, we hear about things like self-harm, people cut themselves, burn themselves, things like that, but wow, pulling your own eyes out.
Yeah.
I'm
Actually,
not.
something that's just occurred to me is that I have assessed I think two people over the years, way before I specialized in forensics, in like medical acute wards, who had set themselves on fire, in acts of deliberate self-harm. And when we would see them, obviously it'd be weeks later when they're in ICU and they're completely bandaged up. So I suppose that's kind of matches the level of severity.
I don't know if that's the right note to end on. Wow. What I will say is I have been absolutely fascinated. I've really enjoyed our chat today. It's really interesting to talk to you. And what I would say about your channel, I would encourage anybody watching, please check out A Psych for Sore Minds. It's a fascinating channel. You can talk about some of the darkest things, but I wouldn't say you do it in a lighthearted way, but you present it in a way that, hi, I'm Dr. Das. I'm everybody's friend. You're so friendly and cheerful at the beginning, and then go into some of the darkest things that human beings are capable of. Wow.
Yeah. I that has been pointed out to me a few times in the past. I think that I think the people might assume that you get kind of inured, or you get desensitized to seeing these levels of injury and violence over time. But I honestly don't think that's the case. I think I've always been able to kind of emotionally detach, but I just coincidentally happen to go into a line of work where that happens to be a helpful trait. I don't think I even sought it out for that particular reason. It's just a coincidence. But I've never been squeamish, and I've been very less easily shocked than other people in similar situations throughout most of my life. So maybe I've got some slight traits of psychopathy. I don't know, but things have never really bothered me, to be honest.
Well, whether it's psychopathy or not, yeah, because I would work with people, as I say, some of the things they're presenting with historical childhood things, terrible things they've been through. Finding a way to, I don't know if this is the right word, but almost maybe it is detached to de-rule yourself, if you will. And I find just having healthy interests outside of my work, friends, family, hobbies, things like that. Don't know if you can say it or not. You're talking to a guy that has a Constitution class starship in the background. I collect antique toys, so having little things like that are a good way of keeping yourself grounded.
Absolutely. Yeah.
Well, as I say, it's been absolutely amazing talking to you. You're a fascinating guy. By the way, I would recommend you get Dr. Daz's book. I've got it for Christmas. Haven't read it yet, but I will.
It's been a pleasure. It's been a pleasure to be on your channel as well, Darren. Thank you for such an interesting interview, and for good questions as well. I do quite a lot of these interviews, and I usually get asked the same things again and again. But you've really pushed the limits of my psychiatric knowledge, so I appreciate that.
Well, the questions I've been asking you are the questions I get asked on my channel that I can't answer, and who better to ask but someone on a higher pay grade than me that knows what he's talking about. Other than that, I could make something up, but I'm sure people wouldn't appreciate that. Listen, maybe it'd be interesting to do this again sometime.
I'd love to. Thank you so much, Darren.
Yeah, all the best.
Goodbye.